This case is about a 17-year-old female with a 2-month history of acute lymphocytic leukemia, for which she was receiving chemotherapy regimen as part of a treatment protocol. She also refers one transfusion a month after the diagnosis. She presented to the emergency department, referring a right hemiparesis as the main complaint, and she refers that it started with a sudden decrease in muscle strength of the right upper limb and aphasia. And 3 hours later, she presented with nausea, vomiting, right side hemiparesis, and facial paralysis. On the physical examination, the vital signs were normal, and she was disorientated and non-cooperative. So the clinical findings in this patient were not specific enough to establish an accurate diagnosis, and because of the history and clinical findings, the infectious, metabolic, toxic, and vascular diseases must be excluded. So the medical in charge requests for a brain CT or MRI. And here I'm going to show you the brain CT axial images. And we can see the supracentral brain. We evaluate the gray matter and white matter. Also, the differentiation between them, which were normal. Afterwards, we evaluate the deep gray matter structures, such as the basal ganglia, acecalate, putamen, and globus pallidus, and also the thalamus and internal capture, which were normal. And it's important to remember that we should evaluate these structures when we suspect for a stroke, as in this patient. And also the cerebellum and brainstem were normal. Finally, we evaluate the ventricular system and the subarachnoid space that present a normal amplitude. So in a patient with suspected stroke and a normal brain CT scan, as in this patient, that we rule out hemorrhage, we should perform an MRI. And also, it is important to remember that CT has a minor role because of its lower sensitivity to detect white matter lesions. So the brain MRI was performed, and here I am going to show you the representative images that were the diffusion and ADC map that show some areas of restricted diffusion with hyperintensities on diffusion that corresponding with low signal on the ADC map at the centrum semioval bilateral, and also at the corner radiata and the white matter periventricular white matter on the corner radiata. And also on T2 weight image showed very subtle hyperintensity on the corner radiata bilateral. So with these findings, the differential diagnosis of bilateral white matter lesions were posterior reversible encephalopathy syndrome. And this patient, the MRI findings of this patient were not consistent with the PRES syndrome because clinically did not have hypertension, and the distribution of the lesion in PRES is usually cortex at the cortex and subcortical white matter, and most often in the parotoccipital lobes. Another differential diagnosis is an acute methotrexate neurotoxicity that we should consider in a in the differential because the patient present a recent onset of neurologic deficit and a known exposure to a toxin that has been described as injuring the white matter. The acute stroke is less likely because the hyperintensities and restricted areas were not on a vascular territories, and the progressive multifocal leukoencephalopathy also was ruled out because these present in immunocompromised patients with AIDS. So this was a case of methotrexate-induced leukoencephalopathy. And as we know, leukoencephalopathy is a structural alteration of cerebral white matter in which myelin suffered the most damage. It is the major and most devastating delay complication of methotrexate treatment, and this disorder generally follows repeat doses of intravenous and intrathecal methotrexate. But it may occur after a standard dose intravenous injection as well. Commonly, the patient presents with seizure or focal neurological deficit, but luckily, the neurological deficits are often transient. And although the neurotoxicity is rare, an acute and subacute neurological symptoms can occur days or weeks after treatment, and a delayed form can manifest several months or years. On imaging, mark is hyperintensities on T2. These hyperintensities are typically located in the preventricular white matter, and particularly in the centrum semioval. For patients with acute lymphocytic leukemia, the incidence is between 9 and 53%, and despite white matter change on MRI, patients often recover spontaneously, including the encephalopathy and stroke-like events. Here I'm showing you an axial T2 and FLAIR images that shows discrete symmetrical hyperintensities in the parietal lobe white matter, as we can see here, and no abnormality was observed on T1. And in this patient, 30 days after the onset of the symptoms, the findings that were previously described disappeared. The diffusion imaging has become important in imaging of the nervous system abnormalities such as stroke, infection, tumor, and it is a sensitive way to detecting cytotoxic edema. That we know it appears hyperintense on diffusion and almost always hyperintense on ADC map, while vasogenic edema is always hyperintense on both ADC and diffusion. Therefore, this sequence helps in the detection of acute brain stroke and also differentiates from other non-stroke-like disease processes. The diffusion abnormalities are usually indicative of irreversible cytotoxic injury. However, in this condition, the diffusion MRI abnormalities are not necessarily associated with irreversible cell death. This was the same patient of the last slide, of the previous slide. And on the diffusion, we can see a symmetrical hyperintense signal in the parietal lobe, white matter, and neither the cortical or subcortical white matter were affected. On the ADC map, we can see a decreased signal that correspond with the restricted diffusion areas. These are another two images of another patient. In this axial diffusion image, we can see hyperintense lesion on the right semi-oval white matter that correspond with a low signal intensity on the ADC map. And on the follow-up, this patient present a partial or interval resolution of the restricted diffusion previously affected semi-oval centrum semi-oval white matter. In our patient, a second brain MRI was performed 5 days after the onset of the symptoms. And by now, the patient present a complete resolution of the symptoms. And here, I'm showing you a T2 and FLAIR images that shows a more evident hyperintensities on the coronal radiata, bilateral, these areas. In this time, there was administered gadolinium, and the T1 post-gadolinium sequence showed no pathological enhancement in the corresponding or in another location. Here we can see the diffusion and ADC map that showed a partial resolution on the ADC map. And also an MRI angiogram was performed, which shows the circle of Willis was unremarkable and no dural venous sinus thrombosis was seen. So an early detection of methotrexate white matter injury by ADC has the potential to alert oncologists to this event and provide a technique by which neurotoxicity can be monitored. And as a conclusion, although multiple drugs are used in addition to methotrexate, the acute neurotoxicity reported in patients with acute lymphocytic leukemia who are undergoing therapy is usually attributed to methotrexate. And acute toxic leukoencephalopathy should be considered in the differential diagnosis of a patient who presents with recent onset of neurologic deficit and known exposure to a toxin that has been described as injuring the white matter. That's all.
Good morning. My name is Javier Gonzalez. I am a theory resident of Hospital Universitario. I'm going to talk to you about a case of a prostatomegaly presenting as a bladder outlet obstruction in pediatric patient. We had a 60-year-old boy who presented at the emergency department with bladder outlet obstruction, and on the evaluation was found to have prostatomegaly and acute kidney injury. He has creatinine of 3.6 milligrams, and biometry was normal. We first performed an ultrasound, which shows this a pelvic ultrasound, which showed this heterogeneous mass behind the bladder, which apparent affects the posterior wall of the bladder. This mass, the visual was up to 97 milliliters, and has many vessels inside. So now once we saw this tumor in the pelvis, we proceed to perform an abdominal CT. The abdominal CT shows this heterogeneous mass behind the bladder anterior to the rectum. We didn't see the prostate, so we can think we thought this mass arise from the prostate. We show this heterogeneous, large mass with many hyperdense areas. No? These areas can correspond to areas of necrosis or cystic degeneration. We can see how this mass affects the posterior bladder, the posterior wall of the bladder, and we are not sure about if it affects the rectum. But what we can see is that there are there are two lymph nodes which are enlarged, heterogeneous, at level of the right external iliac nodes and the common iliac nodes. Also, we can see how are both ureters dilated, no? And we can see how is an asymmetric nephrogenic phase. We can see how is less dense the cortex of the right kidney in comparison with the left kidney. This in relation to the renal failure of the patient caused by the pelvic mass, which was obstructing the ureters. So then, well, we proceed to perform an MRI. This MRI shows the same heterogeneous mass, but we can see how it has a kystic component in the center, which is hyperintense, and the solid part is hyperintense in T2, hyperintense in T1, and has an heterogeneous enhancement with gadolinium. So we can see also how it's affecting the posterior wall of the bladder, and here we cannot see a fat plane of separation with the rectum, which elevates the suspicious of invasion to it. No? We also can see how it's hyperintense in the diffusion wave imaging. This hyperintensity can be for two causes. One, in the center, which corresponds to the necrosis zone. It can be a T2 shine through, and the peripheral hyperintensity corresponds to areas of the solid part of the tumor, which are highly cellular. No? This hiatal image shows the same. The anterior wall of the rectum embedded and the posterior wall of the bladder embedded by this heterogeneous mass, which it was in the topography of the prostate. And this gives us the possibility to say that this mass was from the prostate. So we had a prostatic tumor in a pediatric patient. This actual T2 image shows the same lymph nodes showed previously in the CT, which are enlarged, heterogeneous without fatty ileum. So those ones are lymphadenopathies. And then was performed in cystoscopy, and biopsy was taken which revealed embryonal rhabdomyosarcoma. Well, talking about rhabdomyosarcoma, we know that tumor that originates from primitive mesenchymal cells, rhabdomyoblasts, which are committed to skeletal muscle differentiation. This tumor is the most common childhood soft tissue sarcoma, and up to 70 to 90% occur in head and neck or genitourinary tract. In case of head and neck, the most common site is the orbit, and is equal the incidence on male and female patients. In case of genitourinary tract, is most frequent or most common in males, no, like 2 to 3 times. In case of the males, the most common origin site is the prostatic site. In case of both female and male patients, the most common site is the bladder. So there are 3 types of histological patterns, which are embryonal, alveolar, and pleomorph. The most common type is the embryonal one, with 65% of the cases. Well, now talking about prostate rhabdomyosarcoma, it occurs predominantly in infants and children. These patients are about 5 to 7 years old. It's a highly malignant tumor. That's why we saw it very hyperintense in the diffusion wave image. And the symptoms it's going to be primary urinary obstruction. This tumor is characterized by a rapid growth, which invasion leads to symptoms of bladder outlet obstruction or rectal compression. As we can see in our patient, this mass is compressing the bladder, and not yet, but eventually it was going to compress the rectum also, causing well, colon reconstruction. And what is the importance of the cross-sectional imaging? The cross-sectional imaging is useful or helpful to characterize the primary tumor and to detect spread to local lymph nodes. The diagnosis is made on transrectal needle biopsy or biopsy specimens taken by cystoscopy or surgical resection. Well, on cross-sectional imaging, we are going to all in a pediatric patient who we suspect there is a pelvic mass, we're going to begin with an ultrasound always. Why? Because it doesn't emit any radiation. So in ultrasound, we're going to see in case of prostate radiomyosarcoma, and this heterogeneous mass with some cystic areas or degeneration, invading the posterior wall of the bladder, and with so many vessels inside it. The CT, as I mentioned previously, is gonna be used to review this tumor these tumor margins. Where is the organ of origin? How is it affecting the adjacent organs, like if it originates from the bladder, how it's affecting the prostate in case of the males, the uterus in case of the females. If it arises from the prostate, how it affects the bladder, the rectum, and also it's going to help to determine if we have pelvic nodes or metastatic disease. The metastatic disease is occurs to the lung, to the skeleton, and to the liver. When are we going to perform the MRI? The MRI is going to be performed in case of suspicious of bladder invasion or rectal invasion. Well, these patients, as I mentioned, the sites of metastasis are the lungs, liver, and the skeleton. And the goal of the treatment is the bladder preservation. That's why we have to make an early diagnosis for the best prognosis of the patient. These patients, if the tumor is too large, are going to be treated with radiation and following chemotherapy. If the tumor is localized and needs to be resected, it's going to be resected. Like it can be performed in a prostatectomy in case of the prostate, or if it is in the bladder, then the surgeons can do a partial cystectomy, and then give the chemotherapy and radiotherapy. Well, we need to have in mind that bladder obstruction is an unusual symptom in a young male patients. No, so we have, if it's not something infectious, if it is not an stone, well, we have to have in mind that there is a mass in the pelvis, no? So we have this diagnosis in mind. I mean, it's not very common. It's very rare. It's not very common. With a high index of suspicion, it will help to detect radiomyosarcoma of the prostate before it's too late. I mean, before even there are metastases or before it affects some other structures. So in all pediatric patients with a pelvic mass, we are going to perform first an ultrasound because of its lack of radiation. And then if we see a mass, we're going to perform another study like CT or MRI. That's why it is, because if we make an early diagnosis, we can achieve the goal therapy, which is the bladder preservation, or most important, the survival of the patient. And that's it. Pues si querías, ¿no? ¿Podemos presentar este video?
No, es la presentación, no puedo hacer la presentación.
No, seguro. Aquí está que está. Sí. No tiene notas, ¿eh?
My name is David Blanqueto. I'm a third-year radiology resident, and my case is about a 40-year-old female with past medical history of an appendectomy in 1998 and a hysterectomy and oophorectomy in 2015. The the interrogatory was unreliable as the patient didn't really know why this hysterectomy was performed. Her presenting symptoms were subtle left renal fossa discomfort, and kidney stones were the suspicion. So an ultrasound was performed in another center, and a pelvic mass was identified. We don't have the images, but we performed the contrast enhanced abdominal CT. I'm going to show you a video of the CT. As you can see right away, there's a multiple pulmonary nodules with a soft tissue density, with diffuse distribution. There are no lesions in the liver. There's bilateral hydronephrosis and hydroureter. And there's a heterogeneous pelvic mass, lobulated, and it is enhancing but has some hypodense areas inside. And at first glance, it's tempting to think this is related to the patient's history of hysterectomy and say, well, maybe this is something related, maybe it's residual pelvic mass. Uterine mass. But upon further inspection, we can see that the rectum is displaced anteriorly. So actually, this is a presacral mass. Here are some additional images where you can see the bladder and the rectum displaced anteriorly and the relation that the mass has with the sacrum. So I'm going to review a little bit about the presacral space and its contents. Its anatomic boundaries are the rectum anteriorly and the presacral fascia, sacrum, and coccyx posteriorly, the levator ani inferiorly, and the pelvic peritoneal reflection superiorly. Its contents include osteochondral tissue from the sacrum and coccyx, neural tissue from the cauda equina and branches of the sacral plexus, and mesenchymal tissue from adjacent organs, as well as surrounding connective tissue and blood and lymphatic vessels. So there's a wide variety of benign and malignant conditions that might derive from these elements. We're going to forget for a moment this patient and talk about some masses that can look very similar on imaging. Ewing sarcomas occur in younger patients. So our patient was a 40-year-old female, and Ewing sarcomas usually occur between the ages of 5 and 30. At imaging, they are aggressive and they demonstrate permeative bone lysis, osseous expansion, and sclerosis. Associated soft tissue masses are common. Here, I'm showing two patients, a coronal contrast enhanced T1 weighted and sagittal T2 weighted image, which show an heterogeneous presacral mass with intermediate to high signal intensity at T2 weighted image, and it has heterogeneous enhancement. Most of these masses are better characterized on MRI, but we were limited to a CT. Another presacral mass that can look very similar on CT are osteosarcomas. They are very rare in the spine, but it has a predilection for the lumbosacral region. Patients are on average in the 4th decade of life, and there is a male predominance. Most patients will present with neurologic symptoms, and most of the spinal osteosarcomas are primary tumors, but they may occur secondary to radiation or therapy. Usually, the radiograph will depict a densely mineralized matrix, and CT and MRI image are useful for evaluating the extent of involvement. Soft tissue masses are very common, and typically osteosarcomas are large at the time of manifestation. Here we have another T2 weighted sagittal contrast enhanced and coronal T2 weighted and a sagittal contrast enhanced T1 images where we can see another heterogeneous presacral mass, but this time the enhancement is almost homogeneous. Another presacral mass is chordoma, and they arise from the notochordal rests and are limited to the clivus, spine, and sacrum, or the basis or sacrum. They are the most common primary sacral tumor, and approximately 50% of chordomas occur in the sacrum and coccyx. They are most common in the 4th to the 7th decades of life, but they may occur in all age groups. They are twice as common in men as they are in women, and because they are a slow-growing tumor, patients will typically have non-specific symptoms, including low back and sacral pain, retention of urine, and radicular pain. Given its subtle manifestation, patients are commonly present with a large and bulky mass. They are destructive and lytic lesions that may extend across the sacroiliac joints. And they are locally aggressive neoplasms, and complete resection may be difficult in locations such as the clivus and sacrum. And here we have a contrast enhanced CT, actual CT, and a sagittal T2 weighted image. And we can see in T2 the mass is really hyper intense, and on abdominal CT it's almost homogeneous lobulated mass, very similar to what our patient had. Another possibility is a malignant schwannoma. These are neoplasms arising from the nerve sheath. Although malignant schwannomas have been described, they commonly arise from the transformation of plexiform neurofibromatosis and not from malignant degeneration of the schwannoma. They occur predominantly in men aged 20 to 50 years. Schwannomas occurring in the pelvis are rare and account for only 1% of the cases. Although fairly distinct in clinical and histological presentation, a preoperative diagnosis of a schwannoma is not easy, owing to a lack of distinguishing features on imaging, such as ultrasound, CT, and MRI. Usually they manifest as a large mass, and they might remodel or erode through the sacral bone depending on their origin. A neural origin of a tumor is suggested when there is a neural foraminal widening or erosion. And here we have a magnetic showing a large mass in the presacral region that it's really close to the sacrum, pretty similar to what our patient showed. Another rare but possible tumor is a gastrointestinal stromal tumor. They are the most common mesenchymal neoplasms in the gastrointestinal tract. They are most common in the stomach and the small intestine. When located in the anorectal region, they tend to expand to the rectal wall, resulting in a focal wall circumscribed neural mass. At CT, they have soft tissue attenuation with a central area of low attenuation resulting from hemorrhage, necrosis, or cyst formation. Peripheral enhancement is common. Extension into the ischiorectal fossa, prostate, or vagina might be present. But these tumors present with bleeding as a result of mucosal ulceration, and our patient only had a mild renal fossa discomfort. The images show a actual contrast enhanced T1 MRI and a sagittal T2 weighted MRI that show a presacral mass that demonstrates intense enhancement. This is the mass. Another possibility is a sacrococcygeal teratoma, which is the most common presacral germ cell tumor in children and the most common solid tumor in neonates. These are 3 to 4 times more common in girls, and 60% of these tumors are benign. Less than 10% of tumors are diagnosed in patients who are over 2 years old. The imaging features of teratomas depend on their contents. Benign teratomas contain only mature tissues, including fat, calcification, and small amounts of soft tissue. When they are benign, they are predominantly cystic with fluid attenuation at CT. And the images show a sagittal reconstruction of an abdominal CT and an axial CT, which show a large multiloculated solid and cystic mass that extends into the sacral canal and foramina. And there is bone remodeling and destruction associated. And then it could also, yolk sac tumor, it's another possibility. They are more aggressive at imaging and than teratomas and are characterized by more heterogeneous soft tissues and areas of hemorrhage and necrosis. At CT, areas of low attenuation with no enhancement are seen, and at T1 weight MRI, areas of hyperintensity are seen. Yolk sac tumors demonstrate heterogeneous contrast enhancement and often invade adjacent organs. In these images, we can see why the aggressiveness of the tumor. It is expanding outside of the presacral space and eroding the sacral bone. I have some additional images of our patient to try to narrow our possibilities. As we can see, it is a presacral mass. It's really close to the sacrum, but comparing the left and the right side, we can see here this sacral foramen is occupied and a little bit widened, whereas this one is normal with only fat content. Of course, it could also be that the mass is entering. This does not guarantee that the mass is originating there, but it's a possibility. Here is a coronal reconstruction showing the same thing. On the left side, the foramen is occupied and it has a soft tissue content, and on the right side, it's only fat. And it has a subtle bone thinning in the sacrum. The reality is that on imaging, making a diagnosis is difficult, but we can narrow our options, and with the possibilities, we consider that a malignant presacral mass of neurogenic or mesenchymal origin is the most common, is the most probable diagnosis. It also has a metastatic lung disease and bilateral hydronephrosis and hydroureter. At this time, we don't have a pathologic correlation, but we're still waiting for it. And that is all.